Yeah, the disability and burden of migraine is beyond what you would imagine. Up to 18% of women suffer from migraine at some point in their life. And of those women who have migraine, about 25% have menstrual migraine. And it's got a huge disability. It's considered one of the top disabling conditions, particularly because it hits women in particular in their childbearing years and in their most productive work years. So between their 20s and their 50s, when they're very productive at work or raising their family, whatever the case may be, that's when the migraines seem to peak the worst. So the disability and burden of disease is huge.
Welcome to Breast Intentions, the podcast where we take off the bra of expectations and dive into honest, empowering conversations. We're your hosts, Nadine and Cynthia, two Canadian girls who swapped snow boots for flip-flops in the Cayman Islands. This is your space to feel seen, supported, and a little less alone. So grab a cup of coffee or a glass of champagne and get ready for your weekly handful of truth, wellness, and empowerment. Welcome back to Breast Intentions. Headaches and migraines in midlife can feel confusing and often misunderstood. So today we're bringing in a true expert. We're joined by Dr. Rose Giammarco, a neurologist with over 3 decades of experience, trained at McMaster University and actively shaping migraine care. Based in Ontario, Rose is also the visiting neurologist at Health City right here in the Cayman Islands. And today she's breaking down what every woman needs to know about migraines in midlife.
So maybe if you can give our listeners a little bit of an intro on how you ended up specializing in headaches and migraines.
Sure. I started I was a nurse. I was a psychiatric nurse for a long time. I went into medicine and then neurology. I had a practice in general neurology, and as part of my residency, I spent time with my mentor in Toronto, Dr. Edmeades, who was one of the first headache specialists in Canada, and he really influenced me in that area. So I have migraines myself. I worked with him quite closely, and even though I had a general neurology practice for the first several years, I started to focus more on headache and basically have an exclusive headache practice over the last 25 years. So
now, for anyone who is listening, by the medical definition, what is the difference between a headache and a migraine?
So headache is more of a descriptive term, and headache really refers to head pain. It's not a diagnosis. It doesn't really fit with any of the criteria that the body called the International Headache Society has, where they go through over 200 different types of headaches. Headache would be anything that describes head pain. So you can have headache from sinus issues and TMJ problems and problems with your eyes and so on and so on. It's not really a diagnosis, it's a description. Migraine is very different. Migraine is a brain disease that's inherited in many situations. It has a very specific set of symptoms that go along with it, and those are sensitivity to light, sensitivity to noise, possibly smell, nausea, potentially vomiting. In a percentage of patients, they have something called an aura, where they have a set of neurological symptoms that include perhaps visual changes, flashing lights. They may lose vision, they may have numbness or speech difficulty. So it's got specific criteria as outlined by the International Headache Society itself. They could be episodic, which means they happen 2 or 3 times a month, but then over time, and in some patients they become chronic, so they may have headaches 15 to 25 days in a month. So there are many different subtypes of migraine, but we won't get into that today. So that's essentially the difference.
Okay. Throughout all of my years of coaching, I had probably a handful of clients that suffered with headaches on a daily basis.
Yeah, the disability and burden of migraine is beyond what you would imagine. I mean, up to 18% of women suffer from migraine at some point in their life. And of those women who have migraine, about 25% have menstrual migraine. And it's got a huge disability. It's considered one of the top disabling conditions, particularly because it hits women in particular in their childbearing years and in their most productive work years. So between their 20s and their 50s, when they're very productive at work or raising their family, whatever the case may be, that's when the migraines seem to peak the worst. So the disability and burden of disease is huge.
So it's inherited, you were saying, for the most part, the migraine side of things?
In some cases, yeah, very often there is a family history. And there are some genetic subtypes like familial hemiplegia, which is a different type of migraine, but there are some specific subtypes that are inherited. Migraine in general is felt to have some genetic basis to it in some situations. Having said that, there are certainly patients that I see that don't have any family history of migraine at all. Some patients can develop migraine post-traumatically if they have a head injury without a preceding history.
Oh, wow. Okay. So for many women that do get the headaches and they push through, when is it something that you should actually get checked out? Like, does it just last a bit longer, or is it like a certain level of pain?
So in neurology, when we look at headache, we have something called the red flags.
Okay.
And there's about 10 or 11 different red flags. And essentially, this applies to any kind of headache, but women or men in the general population, if someone has worsening headache, the escalation in the frequency or the severity, if they have associated symptoms, like when they get a headache, they start to get double vision, or they start to get periodic paralysis. If their headaches are associated with fever or neck stiffness, we think about more infectious processes like meningitis, for example. If they have ocular symptoms, glaucoma is not headache, but it can certainly present as orbital pain, which sounds very much like headache. And the one that's most worrisome and troublesome is the thunderclap headache, and it's exactly like thunderclap. Your headache is devastating from the onset. It doesn't build. It comes on very, very quickly. And although there are some migraines that do that, it's called a benign thunderclap headache. It could also be something that's underlying that's more sinister, such as a ruptured aneurysm or a stroke or a bleed into a tumor or something like that.
Right.
So those would be the red flags that we consider. And we always ask questions in the history pertaining to those symptoms. And in some patients, if they do have the red flags, that warrants further investigation.
And so when do they get sent to you? Like, they would get sent to you by their GP, or?
Well, I think it depends where you
Oh,
are. In Canada or in Ontario, you need a referral, so they would have to see their GP or other physician, who then refers to me. Many patients get referred to a general neurologist, and that's absolutely fine. And then if the general neurologist is comfortable treating headache, and they should be, they will take over. But if there's something unusual about it or problematic with the treatment, or they're just not responding to treatment, very often they come to see me.
okay. Why do migraines around your period feel so much worse than other headaches?
Okay. So menstrual migraine or menstrual related migraine, and there are two types. Very briefly, I'm just going to give you the description. Menstrual related migraine is when migraine occurs during the menstrual cycle, but the women will have migraines at the other times of the month related to alcohol or weather or whatever the triggers are. Pure menstrual migraine, which is less common, is just migraine around the menstrual cycle. So that's the distinction. The treatment's not going to be that much different, but we'll talk about that as we go along. But headaches during the menstrual cycle have to do with estrogen stability. And that's the underlying cause, we think, of menstrual migraine. And these studies were done back in the 70s. And sadly, there's not a whole lot more since that time that's really been looked at in great detail. But they looked at women who had menstrual migraine, measured estrogen levels, and felt that the drop in estrogen just around the menstrual cycle was the trigger. So why does estrogen make headaches more sensitive? Well, you know, for example, when you have a procedure, if you go to the dentist, if you have Botox, if you have something else, pain is perceived as more intense during the menstrual cycle. And the reason for that is estrogen, when it's depleted or when it drops, the brain becomes more sensitive to painful stimuli. And also, when you're around the menstrual cycle, prostaglandins are released, and this is a brain chemical that causes inflammatory changes. And that's also why you may get more pain and the headaches may be more painful. But they definitely are, and although there haven't been terrific studies in this area, some of the evidence suggests that menstrual migraines are more severe, they last longer, they don't respond to medication as well as other migraines during the rest of the month, and the rescue medications don't seem to work as well for them overall.
Oh, okay. So then this is where, and I think we're going to talk about it later anyways, is when women are going through menopause and when the estrogen is dropping is when they start to notice
It's all about
these
the
headaches.
estrogen. Yeah.
I've never struggled with headaches at all during my life until my hormones started to go a little bit wonky. And now I notice that I actually get a little bit of a headache a couple of days before my period.
Yeah, for sure. And
So,
everything changes at the age of 40. So even though you're not physically going into menopause, and we'll talk about that, there are many, many other changes as a result of it.
Okay. Okay. Is there anything that women can do before their period starts to prevent migraines?
So we're going to talk about lifestyle, so I won't get into detail here, but as far as medication is concerned, it really depends on the predictability of the cycle. So I'm going to give you a clinical scenario. So a patient comes in, she's her mid-30s, she has headaches around the menstrual cycle. The questions that we tend to ask are your menstrual cycles predictable? In other words, are they 26, 28 days all the time? And does your headache around the menstrual cycle start on a predictable day? Many women will say it starts the day I start my period. Some women will say it starts a day before. And that's helpful. It's particularly helpful if they're on the pill and they know their period date and they know when the headache starts. Diaries are also helpful for this because what we can do is we can do a mini preventative approach. So if a woman has her menstrual cycle every 28 days, her headache starts on day 27. There have been studies using several different medications where on the day before the headache, we start them on a migraine medication such as a triptan, Imitrex, sumatriptan, even naproxen, for example. There's a new class of drug called the G-PANs. So we start that the day before in anticipation of the headache coming on, and they take that medication for 5 days in a row, hoping to prevent the headache from coming on. So that's only if they have a predictable cycle. The more challenging thing is when their cycles are all over the map. There can be 26 days, 28 days. We can't do that. So what we end up doing in that situation is we just give them something that works effectively to take abortively, meaning when the headache comes on. And that's what they do for the 3 or 4 days that they have their cycle. If they have headaches other times of the month, so menstrual related migraine, and their headaches are more than 5 or 6 a month, we generally look at starting a daily preventative medication and then topping them up around their cycle.
Now, I don't know if we're going to get into this later on or not, but from a supplement side, is there anything that a person can do, or are you at a stage where when people are seeing you, like, this is far beyond supplements?
I wish. You know what? My first appointment with a patient is about education and lifestyle. And we can talk about that in a bit more detail, but since you asked about supplements, I'll talk about them here. All of my patients get started on magnesium, and the dosage is either 300 milligrams twice a day. If they have sleep issues, I tell them to take it all at bedtime. One of the side effects could be diarrhea. If they have that, they can back down a little bit, but hopefully stay on it. Another one is B2 or riboflavin. Again, 200 milligrams twice a day, but taking it all at once improves compliance. So take it all at bedtime, 400 milligrams. Although we do recommend vitamin D, there's really not a lot of evidence for it showing benefit, but it certainly doesn't hurt, particularly in perimenopausal women. But then the other one that we tend to start is CoQ10, coenzyme Q10. It's good for many different things, including cardiovascular disease, and there's some evidence that it may help with migraine, and that dosage would be 75 to 100, 2 or 3 times a day. So those are the supplements that we tend to look at, in addition to the other lifestyle issues. And that, that can easily be started before they come to see me, but sadly, most times it's not.
Okay. So going along that line with the medication, with a lot of women being afraid to take medication, are they suffering unnecessarily because of this?
Yes, the pain of menstrual migraine is not fun.
Because I'm guessing there's so many women that just kind of, I'm going to put on my strong hat and I'm just going to plow through. It's just a headache, or, it'll go away, and I can see that.
And, they have it every month and it's short-lived and it lasts 2 or 3 days. But, when you think about it, The question I ask them is, are you missing work? Are you staying home from work on those days once or twice a month? Are you able to look after the kids? Are you missing social functions like your kid's birthday party or Christmas or something like that? And if the answer is yes, then I try to encourage them, just take the medication when your period comes on, take it appropriately, take it early. The other problem is that now, over time, with many studies that have been done, patients who have migraine who don't treat when they're episodic, in other words, if you have migraines 3, 4, 5 days a month, over the years, you have a higher chance of developing chronic migraine by not treating them. So you may end up with 15 to 20 headache days a month. So there are advantages to treating aggressively, treating early when you have the headache to prevent that chronic migraine.
Okay. Oh, I feel so bad for anyone that has to suffer with that. Like, again, I haven't really had a lot of them. Cynthia, do you get them?
No. In the past, I
No,
think I have like probably menstrual related had, I wouldn't even, I don't, it probably wouldn't even be classified a migraine. I think it was probably to
Just a
me just a
headache.
really bad headache.
Yeah,
Yeah.
yeah.
But it didn't last very long. I think it was actually probably when I was starting perimenopause. Like it was
Yeah,
several years ago now. But it is debilitating. Like it's
yeah,
hard to
yeah.
concentrate when you do even have just, I don't know, a mild regular
I, yes,
headache
yes. I
because
just can't
it's just
fathom.
there and you're like, oh, I can't get any work done. I can't concentrate. I can't deal with whatever this person needs me to deal with right now. So yeah, I can't imagine.
Right.
Some people are dealing with it daily and I can't even
absolutely.
imagine.
I mean,
Yeah,
imagine having a migraine where you can't go out, you're in bed, the lights are out, and you have two children, toddlers,
yeah,
at home that you have to look after. And then you're never headache free because the other thing that happens is that when you start taking medication more than 10 days a month, and these people have to, then you have the added complication of developing medication overuse headache, which is from the drugs you're taking.
Oh,
So things
wow.
like Tylenol, naproxen, the triptans, things that abort the migraine and that we encourage you to take, if you take them more than 10 days a month, you start to develop, we call it medication overuse, or medication-induced headache as the proper classification, and that's a daily background headache, but then the migraines occur on top of that. So it's a real difficult thing, and these patients are so disabled by them. And many of them, it's amazing
Yeah.
to me how they still go to work and work under work
yeah,
conditions with loud noises,
yeah.
fluorescent lights, working shifts, healthcare workers. It's just, it's unimaginable. It really is.
I would also be worried about taking that much medication. Like I know the headache overuse, a headache can happen, but also like other parts of your body. Like I feel like, I don't know, your liver, your
Your
gut,
liver.
like,
And depending on what
yeah.
it is, I mean, the triptans
Okay.
aren't typically a problem. The long-term use of triptans hasn't been shown to do anything, and these newer medications have only been around for about 5 years, so stay tuned. But right now, they look to
Okay.
be fairly safe. The ones you run
Yeah,
into
that's good.
trouble with are the over-the-counters.
Yeah, right. Like
Um,
the Advil and the
yeah, and
Tylenol.
Tylenol. And
Yeah.
people think, oh, it's just
Yeah.
Advil, but you get gut problems and GI issues, and
Hmm.
with the Tylenol, you get into things like liver toxicity. So, yeah, there are
Right.
problems.
Yeah.
So,
So going along that line, Advil versus migraine specific medications,
yeah,
what's the difference?
there is a difference. I mean, Advil is something that treats the pain, basically. And Advil blocks that
Okay.
chemical called prostaglandin. So any inflammatory pain, even if it's your back or your leg or whatever, your tooth, the Advil will work. So it's not a specific target. It's simply treating the pain. As
Okay.
opposed to migraine specific medication, and there are two, three, but one's not around much anymore. So the triptans, and for people who've had migraines, Imitrex, Maxalt, Rizatriptan, Elatriptan, there's about 7 of them. And they're essentially the same with minor differences, but those are targeted towards the transmitters and chemicals that affect migraine. And the newer class of drug called the GPANs, called Ubrelvy, I believe that's available now in Cayman. So those medications are migraine specific. They target certain chemicals and transmitters in the brain that will stop the process. So instead of chasing it with pain relief, you are stopping the process from progressing. So that's the major difference.
Okay. Can they be used hand in hand?
Together, yeah.
Or would you yeah. Oh,
I
okay.
mean, less is better. So if I'm giving them a prescription one, I'll tell them to try it. But then they may come back and say, well, your prescription medication worked well, but I still had a little bit of a headache and it was much more tolerable. Then I might tell them to combine that my medication with the over-the-counter one, as long as they're documenting what they're taking so I can see how often that is.
Okay. I feel like I remember many years ago Advil coming out with like a migraine pill that had caffeine in it.
So there's one, we don't have it in
Was there a big
Canada,
thing?
but in the US, there's something called Excedrin migraine. Works great.
Yes, that's what it was.
I mean, it's a
Oh,
combo of Tylenol, an anti-inflammatory, which is Motrin, and a bit of caffeine. So it works very, very well for people that may not have extremely severe migraine. And in Canada, what I basically do is tell patients to take an extra strength Advil, a Tylenol extra strength, and their hit of caffeine, whichever their choice is, and take that all at the
so
same
you,
time.
so you like down it with your coffee? That
Hmm?
kind of thing? Like you down
Yeah,
it with your coffee or
yeah.
really?
Yeah,
Is there a
or
certain
half a
amount
can
of
of Coke
caffeine?
or something like that, because you're getting that caffeine, and that caffeine
No
helps with the
way.
absorption of the drugs too.
Is that what the caffeine is there for?
It does a lot of
For
stuff.
quicker
It
absorption?
does a lot. I mean, caffeine and migraine is a very hot issue. I mean, too much coffee is not good. Too little coffee causes a caffeine withdrawal in someone who drinks on a regular basis. If you have a hit of caffeine when you have a migraine, it may actually help. Like some migraineurs will get up in the morning. I know I get up in the morning and I feel like my migraine is coming. After I have my morning coffee, it's gone. So it's like sleep, you know. I was going to get into this, but we might as well talk about it. Not enough sleep will cause migraine. Having a nap in the afternoon sometimes triggers a migraine in someone who has migraines. Sleeping in or changing your sleep cycle will cause a migraine, which is why many patients wake up Saturday morning and say, I have a headache every single Saturday morning. It's because they've slept in an hour or two. So migraine brains are very sensitive to change. So, you know, if you change your sleep routine, if you change your diet, God forbid you fast and your blood sugar goes down when you're a migraine sufferer, those are all triggers. You know, stress is another trigger to migraine. People, and it's paradoxical because people can function at a very high stress level from Monday to Friday. On Saturday and Sunday, or even on the first couple of days of vacation, their headaches will go over the top. And it's, you know, you think, why? I'm not stressed. My stress was last week. I'm better now. Why am I getting a headache now? It's because of that stress release phenomena. We don't fully understand physiologically how that all works, but I mean, you'll definitely see it in some migraine patients.
It's almost like you're, I don't
Wow.
know, running on adrenaline or you're just like go, 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 go. And then when your body
Yep.
relaxes and
Yep.
lets go of all
That's
that, that's
exactly
when
right.
it
That's exactly right.
kind of ramps up. Yeah.
Yeah.
It's a very fine line then to try to
Yeah.
manage migraines.
Yeah, it's routine, 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 and that's part of the education with patients is try and stick to the routine. It's not fun to get up at 6 o'clock on a Saturday morning and a Sunday morning when you could sleep in, but if you don't, you'll get a headache in some
Yeah, right.
cases. Also, you know, the other thing on a
Crazy.
Saturday morning is you don't, you know, during the weekday you may grab something to eat for breakfast in the morning, whereas on Saturday morning you have orange juice, bacon, eggs, maybe something else, and those are migraine triggers right there. Plus your trigger of sleeping in, and maybe an extra cup of coffee, which will do it again too.
Sounds like you have to be very regimented and very
You
structured.
do.
Yeah.
Yeah, you do. You do.
So, is there ever a case where you may take too much medication and trigger a migraine? I'm guessing so, because it's just such a fine
Well, the
line.
triptans, I mean, the triptans, when they first came out back in 1991, patients were coming in saying, oh my headache's much, much worse when I take it. But I mean, I've taken these medications, and in some of them, during the first 20 minutes after you take it, you get that tightness in your neck, tightness in your jaw, tightness around your scalp. That's the medication working. And it kind of wears off after about 20 minutes as the meds start to kick in. So that can sometimes be perceived as medication making your headache worse. There are some preventative medications that patients find make their headaches worse as well. So it really depends on the individual.
Okay. We're going to move into sort of pregnancy and postpartum a little bit. I'm
Yeah.
assuming there is a hormonal component here. But yeah, if somebody's trying to get pregnant and they do already suffer from migraines, is there something they should be thinking about ahead of time?
So my advice to women when I start them on a preventative and they're thinking of family planning down the line is to speak to me or their physician about what the timing is. Have a plan. If they're on a preventative medication, ideally stop it as your planning goes into play. If you miss that and choose a medication with your physician that could be relatively safe if you do become pregnant, and there are some. Ideally, we stop everything once they're pregnant or before when they're planning, and not try and give anything during the first trimester. It's a key time in fetal development. There
Right.
are medications we can use that have been approved during pregnancy, like the amitriptyline antidepressant class, the beta blockers, propranolol. So those have been approved during pregnancy and are considered relatively safe. There are also acute medications to take, like sumatriptan, for example, and can be taken during pregnancy now. Just recently, they've decided that it's okay. So the key is really education, planning before. Also, if patients have very bad migraine, chronic migraine, you stop their meds, they get much, much worse. Think about that scenario. What's your plan going to be? You have two kids at home, you have a full-time job. Do you have resources? Do you have people you can turn to? Is your work environment something that needs to be addressed during pregnancy? And basically taking it all back to the natural things, hydration and so on and so forth. In terms of medication, in terms of the course of migraine, the good news is that 70% of women get better during pregnancy
Oh,
because
no
it's a
way.
fairly
Oh,
stable estrogen rise. There's no abrupt changes or
yeah.
fluctuations. So 70% get better and they maintain that while breastfeeding. Sadly, the 30% that don't get better, one group gets worse during the first trimester and then it improves as it
Hmm.
goes on. But then there's one particular group of women, and I'm one of those, both pregnancies, where your headaches just went off the rails the entire pregnancy and even into breastfeeding.
Oh, wow.
So it can do one of three things. It can get worse, it can get better, and it can basically be somewhere in the middle. But we can treat them. There are options for treatment, many more than there used to be even 10 years ago. So that's the good news. And in breastfeeding,
That's good to know because I think I would have
yeah,
assumed that no, you can't. You have to kind of cut it all off and suffer through.
yeah, yeah. There are some that we can use. And we go, things like nerve blocks, for example, and even in some situations, some physicians will give Botox because there's no
Oh,
evidence that it
okay.
Yeah.
causes harm at this point.
I
Yeah,
forgot about that one. I don't know if we have that
you
on the
don't.
list, but it
Oh,
Yeah.
is
yeah.
something that I've heard of a lot of people getting.
Yeah. So
Yeah.
Botox, the indication we have for Botox, and it has to be approved and so on, is for chronic migraine. So chronic migraine is 8 migraine days minimum per month, but then another 8 or 9 headache days. So a total of 15 headache days a month. And you also, in Canada, and not so much in Cayman, but in Canada, you need to have failed 3 of the traditional oral treatments before it's approved by insurance.
Okay.
Botox works quite well in chronic migraine. And just in terms of the procedure, it's given every 3 months. There's a total of 31 to 35 injection sites given all at the same sitting. Not very uncomfortable. It's a very tiny needle. So it's very similar to the cosmetic Botox if anyone has that, except that we have more injections involved and different locations in some cases. It works well, and the big advantage to Botox is the side effect profile. So if I have a patient who has multiple medications, who has multiple medical problems, the Botox is something that I would generally look to because it's not going to interfere with drugs. It's not going to give them side effects of weight gain, weight loss, cognitive changes, or anything like that. It's very clean in terms of tolerability. So, yeah, it's
And
been
it's in
used a
like
lot.
the back of the neck. I think some people get it like
Yeah, we
back here.
basically inject frontally here. These are very similar to the cosmetic ones. We then inject into the temple, into the back, and then across the traps. So in people who have a combination of neck pain and migraine, that's obviously also a very good course to go.
Okay.
Yeah.
Oh, that's so neat. I've seen people like get the trap ones done. I have neck pain sometimes, so I'm always interested in that one. So I have to look
Yeah.
into
Also
that.
TMJ. That's,
Yeah, that's a
that's
big one
considered
too.
off-label, but many patients who have chronic migraine do clench, do grind their teeth. And so sometimes off-label, not part of the protocol, we add a little bit into the jaw as well.
Okay.
Yeah.
All right, back to the postpartum. After having a baby, how do you know if a headache is just a headache or if it's something more serious?
So the list of possibilities during pregnancy and in the postpartum period for headache in terms of the differential and other possibilities is very different than it is in the general population of women. Women who deliver babies, women who are pregnant, we have to think of things like eclampsia, toxemia. Women are hypercoagulable, meaning they have more tendency to clot. So we have to think about something like that as a potential process. There are some benign brain tumors, like something called a meningioma or a pituitary tumor, that may be absolutely fine. It's tiny, small, but it grows under the effect of hormones of pregnancy rather. So those are things to consider. Plus there are also other very unusual headache syndromes that can be quite devastating, that can occur during pregnancy. So our index of suspicion in a pregnant or postpartum woman is much higher for something sinister, especially if this is a new headache presentation.
Yeah, right. So what about for birth control? Is that similar to like some women who go on birth control, their migraines disappear, whereas some get worse? Is that sort of like the pregnancy one?
Well, it's all about estrogen again, right? That's what it
Yeah.
comes down to. And when you're on the birth control pill, your estrogen's pretty stable. So your brain is happy. And if it's a low dose pill, many women, their headaches do get better because they don't go off the estrogen and they don't have a menstrual cycle. So they have that smooth estrogen throughout the course of the month. Where they run into trouble sometimes is if the estrogen dose is too high. That high estrogen can sensitize the situation and make their headaches worse during the course of the month rather than just associated with the menstrual cycle.
Oh, okay.
So it's variable and you can't predict, but my rule of thumb is always the lowest possible estrogen dose that you can get away with, and
Right.
preferably continuous rather than placebo during those
Oh,
seven
okay.
days.
Yeah.
Yeah.
What is the connection between migraines and stroke risk? And who needs to worry about that?
I mean, that's a huge topic, but very simply, women who have migraine who are otherwise healthy, who have plain migraine without aura, the stroke risk is not significantly different from another woman compared without migraine of childbearing age with no stroke risk factors. Where we run into difficulty, the thing that seems to be the factor is the aura. And so if you have not so much even just a visual flash of light, but if you have a more complicated aura where your speech is affected, or you have numbness down one side of your body, or you have severe vertigo, or you lose your vision, that in itself, associated with migraine, increases your stroke risk. And then if you add other stroke risk factors, so diabetes, hypertension, high BMI, smoking, for example, all those things increase the risk exponentially. So basically, your stroke risk is not significantly higher in a young woman who's healthy, no aura, and no other risk factors. We start to get worried when all these other risk factors are compounding it, and that's when your stroke risk goes up. And those are precisely the kind of women with those stroke risk factors where we would not consider putting them on the birth control pill or hormone replacement therapy.
Oh, okay. Yeah. So you had said earlier that everything changes at 40. Um, this is the perimenopause time of our lives. Um, for women that do say that my migraines have changed and I don't recognize my body anymore, what's going on?
So during your 20s and 30s, things are good. Estrogen's stable, hormones are stable, your periods are usually regular. And so what happens in your 40s is even before your blood work reflects it, and even before you develop other symptoms, if you think about what causes menstrual migraine, it's that curve of estrogen going up slow and then dropping.
Mm.
If you think about perimenopause, your estrogen's doing this
Right.
up and down and up and down. And every time it drops, you're prone to getting the symptoms. So that occurs even before your blood work will reflect it. So women who come in and say, well, my family doctor or whatever, I had my hormones checked, my hormones are fine, you're just catching a little snip of the hormones when they're getting their blood work. So it doesn't really reflect perimenopausal symptoms. I mean, a lot of things happen perimenopausally before you lose your period. Your weight changes, you develop widening of the abdominal girth, you develop cognitive issues or brain fog, for example, hot flashes, restless leg. There's a whole list of wonderful things that happen. And it's again because of that fluctuation in estrogen. And so, yeah, it's just part of it, unfortunately.
Yeah. All right. What role, if any, does hormone replacement therapy or HRT play in managing migraines?
Okay, so again, keeping in mind the whole stroke risk that we talked about, but as a neurologist, I tend not to delve into HRT, but it doesn't mean that it doesn't help. So what I try to do from my perspective is manage their headaches. So I give them acute treatment. I give them preventative treatments if their migraines are occurring frequently. I really focus on lifestyle issues like sleep hygiene, diet, exercise, the vitamins that we had talked about. And I put them on prevention if I need to. If I think that hormone replacement therapy may help, not because of just their headaches, the only time that I would suggest hormone replacement therapy if they've developed these other symptoms like restless legs or hot flashes or cognitive issues, dry skin, and so on, that's when I would get in touch with my gynae and say, help me out with this, and what's the best thing to take. Preferably low dose, continuous, progesterone only if you're worried about the estrogen, but we make that decision together.
Yeah.
Okay.
Is it true that migraines get better after menopause, or is that just a myth?
No, it's not a myth, but it's unpredictable. You know, if a woman says to me, so are they going to get better after menopause? Unfortunately, there are no studies to say these women get better, these women don't. So the answer to that would be possibly. Many women do. And just anecdotally, in my own practice, I tend to find that women who have a hormonal pattern to their headaches, so did they start when they were 14, when their periods began? Were the headaches associated with their periods? Were they affected by pregnancy in one way or the birth control pill? That woman, I very often will see, may get better postmenopausally. But then that goes out the window because sometimes women absolutely don't change after menopause.
Right.
So wait
Right.
and see, unfortunately.
Yeah. Okay, so we've talked a little bit, we've kind of alluded to things like sleep, stress, diet. What are
Yeah.
the biggest everyday mistakes women make that could trigger migraines?
So I think that, let's talk a little bit about diet. Diet, again, regularity, monitoring triggers. We always recommend protein first thing in the morning and some form of glucose or something to get your glucose up because you slept all night, your glucose is down, and that the brain doesn't like that. The glucose is required for brain energy and production of these transmitters and so on. So diet would be the one thing. Many women don't eat breakfast. Many women don't eat 3 regular meals a day. Fasting for a diet is the worst thing you can do for migraine. So that would be one of the 3 things that needs to be addressed. Exercise, huge factor in migraine. Exercising 3 to 4 days a week makes a huge difference. And I think that that's another one. We're all busy, and so the one thing that goes when we're busy is our exercise routine. And I always tell them I don't need you to spend money and join a gym. Even if you walk 30, 40 minutes, 3 or 4 days a week, that's one thing that you can do. And then the other thing is sleep hygiene. Again, regularity, trying to get to bed at the same time, waking up at the same time. And sometimes it's beyond their control. They're either working shifts, they have young babies that are waking up at night, they don't sleep well, they have stress, they don't sleep well. So those would be the 3 biggest, I think.
I'm sure it can be really hard. And I've seen this in my work with my clients where when you are struggling on a daily basis with a headache or, a really bad migraine, it can be so hard to get yourself to eat well or to
For
get
sure.
outside and to walk and to go to the gym. And
Yeah.
that can be
There's
a
You
no
big
definitely
concern
question.
don't
with
want to
people.
be sitting by the stove cooking meals or
Yeah,
even
for
exercising
sure.
if you have a headache. Yeah.
Yeah,
Yeah, it'd
for
probably just be
sure.
curled up in bed.
Right.
So
Yeah, I can see that.
it's that multimodal approach to headache where it's not just about, lifestyle. It's not just about acute
Yeah.
medication. It's not just about prevention. It's really the whole thing that has to happen together. And there's
Hmm.
small steps.
So,
So
out of curiosity, how long do you spend with your clients when you're meeting with them? Because you must have to learn everything about their lifestyle and
yeah, we talk about all those things. So 45 minutes, sometimes an hour, depends on the complexity. So
that's
it really
great.
varies. There are patients that I see that have been on 5 or 6 preventatives and have been on all the abortives I can give them, and have had a 40-year history of migraine, throw in a post-traumatic headache. So some of them are very complex, and it's a
Yeah.
matter of sorting through. Thankfully, there's a whole new class of medication that came out in the last 5 years that has really made a big difference in migraine treatment. But the problem with that is accessibility. Hugely expensive. Some people, particularly in Ontario, don't have coverage for this sort of thing. So you're back to treating migraines in the 90s with some of these people that
Right.
can't afford them or have no coverage for these treatments.
So headache
And there's
diary. Oh, go
other,
ahead.
no, no, go ahead. Headache diaries, yeah.
Headache diaries. Yeah. They actually help, or is it tricky because people might forget to use them?
Yes and yes.
Yeah.
They, they do help, but the problem is people don't bring them back or people don't keep the diary. And I have some great patients who come in with a diary the first time I see them.
Mm.
And then I have patients who come in with a diary that's 4 pages long that has everything on it. And so the key things with the diary, the reason we use the diary, and this is what I tell my patients from the beginning, is that I want to know when you get your headaches. Mark when your menstrual cycle occurs, when it starts, when it finishes, so that I can see if there's a correlation. Potential triggers, I always give them a list. It's a 4 page list of food triggers. I ask them if they can to keep a food diary on the days that they get their headache to start to see if there's a connection with that. What medications did they take and write those down as well. And so typically when they come into my office, I ask them to keep a 3 month diary. It can be a paper diary, it can be an app, whatever you prefer. I prefer paper because I can see it right in front of me rather than have to scroll through their phone. But the younger folks prefer the apps, and you can get many different apps, and you can also get download paper diaries from Migraine Canada or the International Headache Society in the US. So diaries are critical, because the
I
other thing
agree.
is, for example, for menstrual migraine, you can see it right there when their headache starts, when their period starts. But you can also track them for medication overuse headache, because I can look at that 1 month diary and say, you took your med 12 to 14 days every month. We need to do something about that. It's not a judgment by any means. It's just we need to refocus our treatment and try and bring down those number of headache days. So the diaries are really a critical part. I would say they're step one of treatment.
Yeah. It
I
sounds
think
like it.
that's for anything too, for
Yeah.
people
Yeah.
trying to understand themselves, and you have to be
Yeah.
accountable to like
Yeah.
doing your part as well, because you can't do your job to the best of your ability if they're not doing
Yeah.
theirs with like tracking for you.
But the other thing that it's good for is that if I start patient on a preventative medication and they come back after 3 months with their diary and they say this isn't working and they push it across the desk and say it's not doing anything, but I look at their diary and I say, well, you know what? You didn't take your rescue medication as often. You were taking it 15 days a week. You're now taking it 8 days a week. And your headache didn't go on for 3 days. Your headaches are there, but they're only lasting a day. So it's not the number of headaches, it's not the number of days, it's are they responding better to medication? Is their quality of life better? Is their absenteeism from work better? So there's so many factors to look at for results in medication and treatment,
Right.
not just the number of headache days.
And it's one thing to sort of think like, oh, I think it's getting better, or I think I just have them randomly throughout the month. But then seeing it written down and seeing these patterns or seeing if
Absolutely.
there was a food
Yeah.
that triggered it or lack
Yep.
of sleep, whatever it is, seeing the pattern helps, I think, for everything, for headaches and other things as well.
For sure.
So if someone wanted to start today to reduce migraines naturally, what are the top 3 things that you would tell her to do?
So I'll break that into categories. One is lifestyle and addressing things like sleep hygiene, exercise, diet, not skipping meals, minimizing their caffeine to no more than 1 or 2 in a day, and keeping track of potential triggers. So those are sort of the usual lifestyle things, and stress management, obviously. Then I would say the vitamins. Those are easy things to start, and we talked about that. So I would start the vitamins as well. And then the other thing that I would encourage them is, if they're prescribed medication, to give it at least 3 months, because the preventative medications don't start to work until it's about 3 months. And don't be disappointed if the first one doesn't work the first time. I always tell them, with high blood pressure, family docs will start you on 2 or 3 things before they find the best one for you. Migraine's no different. We may have to do 2 or 3 trials of a different medication before we find the right one, and it's important for you to stick with it, right? So many will say, that didn't work, I'm not going back to see her. Or she's given me vitamins, she doesn't know what she's talking about, she didn't give me any medication. So there are so many things that come into play. So you have to have that discussion up front about waiting 3 months. If it doesn't work, I'm going to be giving you something different. So those would be the things.
All right. And one last question for you. What's something you wish every woman knew about migraines that could completely change how she manages them?
Lifestyle.
Yeah.
Lifestyle, and treating and sticking with your treatment program. Those are the 3. Yeah.
Right.
It can make that much of a difference.
Oh, for sure. I have patients who come in and I don't touch them with medication just because they're all over the map in terms of not recognizing when they occur and triggers. So for the first visit, for 3 months, I give them no medication other than maybe a rescue to take when they have the bad headache, with instructions not to overuse it. And they come back and they've started the vitamins and they've changed some of their lifestyle. And I do have patients that go from 15 headache days a month down to 3 or 4
Yeah, wow.
just by monitoring those things. So it does help.
That's great.
Yeah, that's amazing. Well, this was very interesting. And I'm like, it sounds like there are things that women can do if they are suffering,
For sure.
which is great. I mean, I'm sure when you're in it, it doesn't feel like you can do anything to help. But this was a very interesting conversation. Thank you so much for joining us today.
You're welcome. My pleasure.
Yes. Also, you are based once a month in the Cayman Islands, out of Health
Every
City.
6 weeks. Yep. I
Every
am.
6 weeks. Okay.
Yep.
And then you also have a clinic out of Hamilton, Ontario.
My office is in
well.
Hamilton, right?
Yes. Okay. Okay. So just for any of our listeners, especially people who are based in the Cayman Islands that do. Now, can they just book an appointment with you, or do they need to go through a referral from their doctor?
No, I think they just contact the Health City at Cayman Bay and tell them they want to see Dr. Rose at the headache clinic, and they book right through Health City.
Okay. Perfect.
That's
Good to know.
wonderful.
Okay. All right.
Well, thank you very much. We really
My
appreciate
pleasure.
this.
Thank you.
Yeah.
Thank
Okay.
you.
Alrighty.
Bye.
Enjoy your day.
You too. Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!